Hello, future PTAs. Welcome back for the second PowerPoint on Chapter 2 for our modalities course. All right. So here's our outline of what we're going to go over. You can read, but the history of physical agents, we covered a little bit of it. Essentially, in the ancient Roman and Greek culture, they used heat, they used water to treat musculoskeletal and respiratory problems. They also used some electrical stimulation, but through a electrical torpedo fish that they used to treat different types of arthritis, and even headaches were treated by some modalities. And then for a while, physical agents, or what we call modalities, fell out of favor, meaning that people began questioning the use and if it was really effective. The APTA has done this Choose Wisely campaign, which essentially says there's not a lot of evidence that supports the use of modalities for certain conditions or modalities by themselves. So essentially, their take is if all you're doing with is modalities, that's not physical therapy. It has to be in conjunction with other treatments, exercise, stretches, all the functional mobility, all the things we do in physical therapy. And the other take is that you need to choose wisely on when to use them, when not to, and make sure that the benefits outweigh the risk, and that you have some type of evidence of why to use it for that condition. Some of the approaches to rehab. So these are just describing the effects a pathology has on the whole person. I wanted to say that the way I had it written. The ICIDH, I know that I won't remember what that stands for completely. That acronym stands for the International Classification of Impairments, Disabilities, and Handicaps. That was kind of the first approach that was used back in the 80s. It was a linear model, and it just basically explained how pathologies and diseases lead to disabilities and handicaps. After that, the Naji model was used, that also looks at more all-encompassing way of looking at a patient. And so they looked at pathology, impairments, functional limitations, and disabilities, but the focus was more so on what was wrong versus on the whole person and how to help. So what we currently use most often in the clinic is the ICF model. Um, and in that model, we're using function and disabilities, looking at them. They're a complex, dynamic, association between health conditions and contextual factors, but here we're focusing on how to help, what is right, and getting the most function back for a person. So this is what we'll use most often. It also has the health condition here up at the top, has body functions and structures, activity limitations, participation restrictions, environmental factors, and personal factors. And you're looking at all of that, how things affect the patient, so that you can best determine how to help them get the most out of their life and with their current condition. Here's an example of a quick little scenario and where each part of the scenario fits into the ICF model. So for a 19-year-old female soccer player, she tore her ACL. She had surgery a month ago. She's still using crutches to walk. She has difficulty going up and down stairs to enter her apartment. She's unable to return to soccer this season. Her family lives in another state, so she doesn't have a huge caregiver support. She's made very few friends outside of her teammates, so she's kind of there all alone on crutches with stairs to go into her apartment and needs some help. So when you're looking at her as a whole person rather than her coming into your clinic and you just seeing a knee and just treating a knee, you start thinking, okay, we really need to help her get more independent with these crutches so she can get up her stairs, or we need to help her find some caregiver support and maybe show her some resources that she could, point her to what she has available to her through her college or whatever. And so one way of looking at her as more of a person, not just a knee, is by looking at every category, determining what is her health condition. It's a torn ACL. What body functions and structures are we talking about? We're talking about pain, weakness, limited range of motion, gait instability, things like that. What activity limitations does she have? Unable to walk, unable to run, unable to go up and down stairs. What participation restrictions are there? Unable to play soccer, unable to attend class. For the environmental factors, the stairs going into the apartment, the long walks on campus, maybe the drive to campus, all those we need to consider. And then personal factors, of course, lack of family or caregiver support. Maybe she has any type of comorbidities. Maybe there some transportation issues. So looking at her as a whole person and determining how can we help her best, whether it's just helping her decide how can I get to therapy or helping her figure out how to use the crutches so that we're not only treating a knee, we're treating a patient, a real patient that has more than one thing going on. um, so the role of physical therapy in rehabilitation. So the APTA of physical agents, I'm sorry, in rehab. The APTA stance, again, is saying that we need to be careful what agents we use. We need to have evidence that we can use them or that they're effective for the condition. And this statement is specifically saying if all we're doing is a bunch of modalities, that's not physical therapy. Modalities in themselves, if that's all you're doing, is more like a, wellness center or a spa day. You have to have those in conjunction with real other treatments, not that these aren't real, but other physical therapy treatments in order for it to be considered physical therapy. So if a patient's coming in and all they're getting is heat, e-stim, ultrasound, ice, and then they're out the door, you might have made them feel a little bit better, but the APTA is saying this is not true physical therapy. You need to do some exercises, some mobility, some range of motion, something that makes it true physical therapy. Who all can use modalities? PTs, OTs, athletic trainers, psychiatrists, chiropractors, acupuncturists, and even patients themselves, especially lately, those massage guns and home TENS units and different things are becoming more and more popular. So, um, each person may use them for a different purpose or may have different parameters or different goals that they're working towards, but all types of people can use those modalities. Evidence-based practice. So we want to use the current best evidence in making decisions about what care we give to a patient, whether it's modalities or exercises or anything. Evidence-based practice is the best way. You're applying the scientific method to provide the best care. So you're kind of assessing the research, determining what seems to be working best for this type of patient or this type of injury, and that's the treatment that we want to use. The different levels of evidence, so from highest to lowest is how we have them listed here. Your meta-analyses are the most um, highest quality that we want to look at and take into consideration, then systematic reviews, then randomized control trials, cohort studies, case studies, and then case reports. So looking at each, and when you're reading evidence and you're saying, oh, well, this worked for this one patient really well, if it's just one patient, can we really look at that evidence and say that means I need to start using it with every patient? So, you know, understanding what you're reading and how reliable and helpful it is important in using evidence-based practice. PICO is an acronym for Patient Intervention Comparison and Outcomes. It's kind of a way of looking at research to determine what you're reading and how to use it effectively. So patient is the population or group that the research applies to. Intervention is the treatment that they have focused on. Comparison is saying, was there a control group or was it just, one group that was looked at? And then the outcome, what were the results of the research? Some of the sources, these are just different databases and things that you can look up research on so that you're using evidence-based practice. The APTA is also a very good resource for us to look up information and determine what is the best evidence pointing and what treatment should I be using. There are also clinical practice guidelines, and these are basically statements developed where groups go through and they read the current research, they interpret it, and they come up with statements based on what they recommend using, not using for different, ailments or different populations and things, based on the current research. So it kind of takes some of the work out for you. They give their recommendations on what to use and what not to use based on current evidence. Some of the sources of these clinical practice guidelines are listed here: the International Guideline Library, the National Institute of Health and Care Excellence, the CPG Infobase, Guideline Central, and then again, the APTA has a lot of statements that they release based on what they recommend based on the current evidence. When you're using physical agents in different settings, you also want to look at if it's cost effective. There are reduced reimbursement rates for some of them. I know some clinics don't even charge for hot packs or ice packs anymore unless they use eSTEM or something with them, because the reimbursement is not really worth even doing the paperwork. So determining what's best for the patient, but also what is cost effective and may get reimbursed. And then making sure that you have the right documentation to show that it was necessary and why you did it, how you did it, something reproducible that someone else could do. And then assessing the response to the intervention. So just determining, was it effective or not? All right, that is all for our chapter 2. So we will continue with chapter 3, and that will be the last one for this lecture.